Good morning, everyone. It's May 8th, and you are 2023, and you're joining us for another Community Conversations from Health Advocate X. I'm Robin Shapiro, and I'm the board chair of Health Advocate X, and we have a really interesting community conversation teed up for you today. So before we begin, I just would like to establish this meeting as a safe space. And you all know what that means, but I'm going to remind you, it means that every voice will be heard and respected. And as we move in space, we understand that we come from different lived experiences. And as such, we recognize the potential for unintentional harm. And we're committed as an organization and a community to healing should harm occur. And I would also like to give the following land acknowledgement today. I'm back in Seattle. I just got back in late last night, and I'm speaking to you from Seattle, Washington, which is part of the unceded land of the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people. And so I'd like to acknowledge the Duwamish, Suquamish, Muckleshoot, and Stillaguamish people and community and pay my respects to their past, present, and future elders. And I invite you to do the same for the land in which you are living, working, and playing as well. So today we have with us Dr. Dale Reisner, who was the former medical director at Swedish Health Services. She's been leading the medical part of these community conversations for a very long time. And we also have a special guest, Michael Millenson, who comes to this conversation with an unusual background as a journalist and professor. He's going to be talking to us about data democratization and what that means in terms of being able to own and understand your own medical information. So before we have Michael do his part of the presentation, we'd like to invite Dr. Dale Reisner to catch us up to date on COVID and any other public health information you'd like us to know. Dale?
Yeah. Hi, everybody. So I wanted to maybe do a final overview of global and US COVID cases. We will be talking about COVID certainly at other points in time, but there's a lot of interest in many other things. I do hope that we can do a long COVID update in the near future because there's more information available. And I know that's something that you will encounter with working with your clients as well as with family members, perhaps, or yourself. So globally, we are now at over 765 million cases with more than 6.9 million deaths.
Wow.
Obviously, reports, as I always say, are based on who's reporting and the accuracy of that. We totally know that not all cases are being reported. So I think always saying over a certain amount gives us the sense of where we're at. In the US, it's over 103 million cases. And this is as of the 3rd of May. And this is World Health Organization data, and greater than 1.1 million deaths. And I have mentioned in this platform before that the death rate is a little higher in the US than it has been reported across the world, whether that's a reporting error or whether that's relates to our healthcare, which we all know is not ideal. And then I also wanted to mention that we've talked about pandemic versus endemic, and I know a lot of people are talking endemic these days, and we are not quite at the official definition of endemic. So as a reminder,
Really?
Yes,
I thought we were. Okay, well, it's good that you're reminding us.
That is, people are saying we're headed there. Fewer than 100 deaths per day, I'm talking about the US, okay, would be endemic. And steady, predictable rates typically. So similar to the flu, we have steady, predictable rates. It has its season and so on. You know that we don't have that yet with the COVID-19 virus. What is really good is that if you were on last month, I think our average daily rate was over 200 to like 230 to 250. In the week ending with 5/3, it's 158 per day. So we're getting really close, fairly dramatic drop. The question that we all should have, and the caution, is that in the spring last year, we had a drop as well, not this low, and that we are likely to see lower rates through the summer and see a big upsurge when people get stuck in buildings and back to school and all of those things by fall. So this is that pandemic versus endemic. I actually don't think it matters. We've had a really long pandemic. We're headed in the correct direction. Whether, if you want to be accurate, don't call it an endemic yet. But your behavior should be according to what's going on. So what's going on right now is that there is a new variant that is circling. It is an Omicron variant. The original Omicron is basically gone. And this is what is it? It's XBB 0.1.5. Not that you're not going to be tested on this for your
Thank goodness.
CEs.
Okay.
But just so you know, there have been obviously many different variants that have come along. It is very infectious. It does not seem to create any more severe disease and may even be milder. And so you'll hear these things in the news, and just know that we're expecting new variants to come along. And as long as they're not increasing the death rate, and that you're doing your own personal protections, you don't need to really be too worried about these new variants. They have all acted very similarly, which is very wide range of symptoms for people who get the disease. Some, more associated with the no smell, no taste, some with the fevers. So just know that this virus will continue to do that. We have that with common cold. We have that with the flu. And then the other news that you may have seen is a decrease in the CDC tracking and the World Health Organization sort of reframing how they are tracking. Do not worry. It's not like they're giving up tracking altogether. It's just that your individual data is not going to be requested. They're ending the electronic feedback.
The visa.
Yeah. Right. And so they're ending that. I think it's done as of now. But they will rely on public health across the country and in the various other parts of the world, with both local, either county or hospital-based rates. And it's my understanding they'll continue to at least spot check wastewater for surges and for trends. And so the trends are really what we're going to be talking about, rather than so much individual cases. And that makes sense, because people are testing at home and they're not reporting their results and all of that stuff. What I do want you to know a little bit about vaccination is in the entire world, over 57% have had the initial series, the full series. That's pretty cool. Over 10 billion vaccines have been given worldwide. In the US, our vaccination rates that I've quoted before are quite high for at least one dose, and we're quite low for the bivalent Omicron included booster. Those booster rates have picked up a little bit, and now really what's happening is the recommendations are focusing on who should get boosters and all of that. So I'm just going to.
So do you think we'll be annually boosting, just like flu, or
yeah. I don't think this thing's going away.
Yeah, gotcha.
The current recommendations focused on the bivalent booster now, rather than waiting till fall, are for over 65 years old. They're recommending a second of the bivalent, or that updated either Pfizer or Moderna. Both of them have it. And if you have moderate to severe immunocompromised. So these are the two high-risk groups that we've been talking about the whole time.
Bill, do you know if it's available? Because I heard from someone who said that it's not available. Maybe it's not available everywhere.
It may not be available everywhere. So you can get on your state's Department of Health and look, say, I want a vaccine. Where can I find it in your locale? And you should be able to find it state by state or region by region, county by county. So yeah, it may not be at every single site. And again, that's a supply, stocking and all of that kind of stuff will become more of an issue. So yeah, and then for younger, for everybody, they're saying have at least one updated Pfizer, Moderna, so that bivalent is their recommendation for 6 years and greater. And for younger, they're not keeping their immunity as long, so they're actually talking about the younger kids 6 months to 5 years old might need more. So that's going to be a pediatrician recommended thing. I'm sure the American Academy of Pediatrics will come out with fresh recommendations on that.
Well, and maybe, we're going to do in the fall before back to school, we're going to do a back to school kind of a community conversation.
Probably.
So
probably
that's
good.
what that's what we're talking about. Yeah. And
so right
Dale,
now,
also, Patsy Stahl wanted to know if the new variant, she heard a new symptom is red eyes, such as pink eye. Have you heard that?
Yeah.
Is there any data about that?
It gives you a conjunctivitis type of thing. Not everybody gets it, but yeah, it can be, that can be a symptom. That's why I highlighted that the symptoms for each of these variants may change a little bit, but it's the same basic virus.
Gotcha.
So I just want to finish with kind of where a reminder that when you're vaccinated, you have a lower risk of hospitalization and death. And you also have a lower risk of long COVID. I took a look at myocarditis because again, this keeps coming up. If you get the wild disease, of COVID, whatever variant it may be, there is a risk of myocarditis. We knew this. That risk is a little bit different age by age. I'm not going to talk about that. But when you look at what the rate we had was 150 per 100,000 population people, right? That would be about 1,500 per million. From the vaccine, there have been 8.5 cases per million compared to 1,500 unvaccinated. So if people start asking about, well, the vaccine's associated with myocarditis, yes, it is. Go buy a lotto ticket. You're going to have better odds. So yeah.
Wow.
So I just wanted
that's significant.
to mention that. That's also part of the kind of putting it into perspective. So current recommendations are, update your vaccinations if you haven't, if you're in a high risk category. Continue your frequent hand washing, avoid close contact, particularly in people that you don't know, or the people that are exposed to a lot of other, children or whatever, and mask in public places if you want to protect yourself, and then avoid, obviously stay at home if you have symptoms. So, avoiding even in stores and stuff, if you can try to keep that 6 foot distance, you're going to protect yourself a little bit. You don't have to be crazy about it. You can just do your own thing. And I'm feeling that, I'm seeing that very few people are masking. And I'm feeling that the closed line spacing is getting shorter and shorter. And so I put like carts in front of me or behind me to keep people 6 feet away, even if I have a mask on, because who needs to be sneezed on for, catching anything. So that would be the current recommendations of mine and those from CDC.
Yeah, that's great.
Yeah.
There was also a question in chat about if Medicare is covering the bivalent Part B medical or Part D drug coverage. And I don't know if you know the answer to that, but if anybody, you do?
I don't, but they should.
Yeah.
So if there's a problem with that, they should be covering it.
And if anybody has the answer to that if they can just throw it in the chat, that
Yeah.
would be great. Wonderful. Thank you, Dale. That was great. And gosh, we've come a long way, but we're not quite there yet.
Yeah. Yeah. And
so
I'm going to come
appreciate-
off screen because I really want to be able to have everybody concentrate on Michael, and
Yep.
and really anxious to hear what he has to say for us. So
Thank you so much. So I'm now going to go ahead and share Michael's slides, and we're very excited to have Michael Millenson, and he's just put this right up here. And he's an unconventional background and self-proclaimed activist for better, safer, patient-centered care. And we all know what that means, but he has a unique take on that. And he's a Pulitzer Prize winning nominated journalist and professor. And we've had a really great time prepping with him. Can't wait for you to hear his presentation. So take it away, Michael.
Okay, I'm seeing I'm seeing a different view, like the side of the slides and the front of the slides at the same time. Does it need to be the slideshow view?
It is the slideshow view. Let's see. So I'd say let's.
There we go.
Okay. Good.
Well, thank you. Thank you,
Yeah.
Rob. And I appreciate the invitation from Health Advocate X. Patient advocates are, as far as I can tell, little known and appreciated a great deal by those who know about you, and utterly under the radar for other folks. And I certainly have recommended to friends and had pretty good experiences and on occasion myself. So I'm delighted to be presenting. I do have an unusual background. I went from, go to the next slide for a moment. You just showed wrong slides.
Okay.
Yeah. It's the version that's the older version. The version I sent this morning is what you need to go to. And while we do that, I wrote a book in 1997 called Demanding Medical Excellence, Doctors and Accountability in the Information Age. And I did this with an academic grant. I left journalism. I was a reporter at the Chicago Tribune. And it radicalized me because that should be right. Thank you. It showed me the difference between meeting room reality and in the trenches reality. And I had a really tough time getting my head back in mid-1990s around the concept that doctors could have evidence that they've seen in the medical literature, and yet it did not change behavior. It was very hard for me to get my head around. And I wrote about patient safety, evidence-based medicine, patient empowerment, buying, what we now call buying on value, and informatics back in 1997. And unfortunately, it's all still relevant, progress being what it is. But I think that we're about to have really rapid change because, in fact, the information age is arriving, and people outside the usual suspects, the usual pharma, the providers, the hospitals, the insurers, with the tech companies and others, information is changing everything. And your role as information changes everything will change. So I understand that access and costs are important and the bread and butter of what advocates often do. I'm going to focus on the clinical, knowing that some of the supplies elsewhere, and then happy to have a discussion. So next slide, please. So as in other industries, the availability of information and knowledge is enabled the democratization of healthcare. That's kind of our theme, is that traditionally professional knowledge was very closely held. And what's happened for a lot of reasons, Google and patient peer discussion groups, a lot of other things, knowledge is becoming democratized. Now, this isn't new, right? We had our bodies ourselves was a huge, impetus to this back late 1970s, I guess, or mid 1970s, actually, our bodies ourselves. And then we've had the Merck manual people have gotten and all the rest of that kind of thing. But the internet has really supercharged that and made it easier for everyone to partake of it and truly democratize the information. And by the way, although I'm going to talk clinical, as we know, price information, access, a lot of those things as well. Next slide, please. So this is a slide showing I own my own health information. And it comes from David Brailer, the former head of the Office of the National Coordinator for Health Information Technology. But what it shows is all the different kinds of apps, home monitoring, passive sensors, mobile, voice, all the rest of this, that basically owning your own information is no longer having a really nice fax, right? Or even just a PDF. The key is you're owning your own information as data, as computable biomedical knowledge, as the academics say, and that's the key. And that it becomes something that's not only you can look at, but something that can be manipulated and used to find out other kinds of personalized things. And what I call this, by the way, is back in the 90s, the medical establishment and some patients got together and they said, nothing about me without me, right? But what I call this is nothing about me without me, but sometimes without you. You can be as patient-centered as you want, but I don't always need you. Just like my bank may give great customer service, but I still use Venmo. And this is where democratization is changing the power structure. And it's something that is not fully realized yet, but is happening and is really extraordinarily important.
And Michael, go ahead and tell us again what you mean by democratization.
Democratization of data means that it is no longer held by one group, that Open Notes allows you to get it, that there's but that also you have access to up-to-date and the medical journal articles and all the rest. Now, do you always understand it and all the rest of that? Not necessarily. We're going to get to ChatGPT in a moment, but it means that it's not that everything the doctor knows from their own experience is devalued. I want to make sure I emphasize that. It does not mean that you should be your own doctor and decide to treat yourself based on the first page of your Google search.
Yeah.
Or what.
Right.
That's not a good idea, but it does mean that you can have expert, reliable information that your doctor also has access to, or that they can't know from patient-generated health data, right? So if you're generating your blood pressure over a period of time, that's going to be more accurate than white coat generated blood pressure, a lot of other things. So, and I go this in question and answers. I think we're coming to a new kind of collaboration between doctors and patients, which is a good thing, but is a slow thing. Next slide, please. So we're going to do a case study here, data democratization, a cancer journey. And this is something I've put together, but is possible. So let's go through it. So we have Patricia Washington, a Black woman who's a middle manager at Megacorp, who's diagnosed with breast cancer. Fortunately, her advocate's savvy about digital platforms, can keep her informed and empowered, whether available online or from an employer. So let's stop here for a moment. No, my friends, this is not merely looking at the App Store from Android or Apple. There are sophisticated platforms that even if you are not, your employer may offer. Okay, this is what democratization means. It's not just somebody who has a PhD from Stanford and decides to, have a bunch of apps downloaded. It's anybody with guidance. And what's interesting here, this is outcomes for me, but also you have Citizen and others. You start to have all your data in one place. What does that mean for you as an advocate? That you have all the data from this person that went to a bunch of different hospitals, that you have all sorts of what outcomes for me can tell you which clinical trials work best for you, or which guidelines from National Cancer, NCCN, National Cancer Care Network. And now also the patient's going to be in some ways more in need of your expert guidance. Because now, right, all of us know that, okay, it's great to have all that financial information available online, but sometimes we can get confused and we need a professional to say, what does it all mean? So this both provides new knowledge and new confusion, which I guess is good news for you because you get paid to clear up confusion. So it's great. People are confused. They need you even more. What more could you ask for? Next slide, please. So speaking of confusion, I've been playing with ChatGPT and I will tell you right now that when I ask this question, what is the survival rate for breast cancer? And I put in the words for a patient with breast cancer, it changed the search results. So intelligent it may be, but its intelligence varies depending on exactly which words you use. So I said, what's the survival rate for breast cancer at University of Chicago? And I made sure I referred to their cancer center exactly as they did. And it said, sorry, I'm an AI language model. I don't do this stuff. Okay, but talk to your doctor. Great. Now, next slide.
So fascinating.
Bard has gotten a fraction of the publicity, but it's out there. And when you ask Bard, look at this. I've got a 5-year survival rate given, and a source, the National Cancer Institute. I did something about knee replacement surgery, and I asked about the highest volume hospital for knee replacement surgery, and then the highest volume surgeon who turned out to be at that hospital. And I got an answer from Bard with attribution, which kind of blew me away. So
meaning the source information that they're drawing it from. Yeah.
Healthcare Blue Book,
Yeah.
right? The source they're drawing on, exactly right. That's going to start some different kinds of conversations for sure. But the point of this is that these are okay. They're getting better. But what's really exciting to me is going to be what happens when you take this technology and you apply it to more reliable databases than just, the internet or whatever the heck they're doing now. And that's going to be pretty interesting. All right, next slide, please. So in the hospital, we have our patient there. She is confused, emotionally difficult. You need the advocate to keep you safe in the hospital and to help communicate with your team and to understand what tests they're ordering and all the rest of that. That is really important because it turns out that when you're sick and you're not that good at taking care of yourself. And all of us in this field have heard stories about physicians who are in the hospital and need someone to look after them, or have actually, before they go under, have saved their own lives or whatever, or looked at some things. I mean, it's just the way it is. So whatever technology we have, on the other hand, you may be the person who looks at the patient portal while that patient is in the hospital in real time to help keep the infusion from happening that shouldn't. Something happened with my sister and other kinds of things. So your job in some ways becomes more difficult because you have to deal with an information flow.
And what you're describing also to me is like a 3-sided stool where you have where the information is coming from, right? So the source data, which varies right now and is not totally reliable. Then you have how you ask your question to extract the data that is available. And then you have the third stool, which is applying it to whatever the patient situation is. You have to have all those aspects in order to be successful in helping.
It's not even just how you ask your question, which I think is correct. It's all the different data inputs. Mm-hmm. Advocates will be more sophisticated at evaluating the information. Mm-hmm. That's the key, is that, it's like used to be with buying a car, right? Before we got even better information. You bought a car once every, 5, 6, 10, whatever years, and the car salesman sold cars every day, right? So there's an information asymmetry. What the advocate has always done is help with the information asymmetry. What's happening now is the task of helping with information asymmetry is becoming a bit more complex.
Mhm.
But at the same time, it's becoming more complex because the information asymmetry is lessening, right? So that's the thing, is that, you know, it's much more of a balancing act.
Yeah.
Next slide, please.
Yeah.
So after Patsy's out of the hospital, where, by the way, she also has to make sure about the advocate about equity and equality of treatment, because we know that there's differences even when you're in the hospital, even when your clinical signs and symptoms are all the same. It turns out that data is not enough to get rid of inequity. Who knew? And that we have patients like me, which then you can filter for those kinds of things. And the thing that's interesting is this is not just a chat room, right? It used to be at the beginning of the web, you go and you talk to other people who had the same condition, go to a patient support group online, and those still have an important part. But they run this data through analytics, right? And
I just want to make sure, because some of the folks on the line probably have heard of patients like me, but some might not have. So in terms of that organization, maybe just a quick 2 sentences about patients like me.
A group of brothers who are, I guess, techies and engineers formed this because one of their brothers had, I guess, Lou Gehrig's disease, and there's no known cure. So they said, let's get the people who have this together and talk and exchange information. And eventually it morphed into hundreds of conditions with analytics where people exchange information about what side effects did I have from this drug, what worked, what was my functional status, a whole group of things which you can blow up the slide eventually and look at. And it became a sophisticated thing which they make money by selling, the information with your consent for clinical trials where you want certain patients and things like that, but can be a great source of data and frankly comfort, because you look at what's happening to people like me. And in a sense, it's parallel to what the physician has always said, in my experience. Well, his or her experience is fine, but is limited. What this does is blow up in my experience. And obviously I'm all in favor of sharing information with your clinician. All of us have had the experience of going online and being absolutely certain that we now had an MD, and then perhaps finding out that perhaps Googling was not enough to actually give us a medical degree. On the other hand, the other thing works as well, right? You discover some things that your doctor didn't know. So it requires humility on both your parts. Next slide. So here's what I think the opportunity is. You all have a perspective and experience that can help take the clinical evidence that's coming out through, frankly, making it easier to search through AI and other things, the kind of other human side that's going out, and put it all into perspective. That's kind of becoming your job, along with the other things. And the other thing is you're going to need expertise updating. I mean, maybe this is a job for some of the coalitions of advocates to keep an eye on this, because the whole ChatGPT thing has changed things enormously, but there are a lot of other AI databases going out here. I mean, I found some of this stuff by systematic searching and also by looking at the literature, which is fine, but that's serendipity. And maybe you need some folks by condition or whatever to look at this. I mean,
and also separate out the wheat from the
chaff.
chaff, right?
I think that's important as well. I did an article a few years ago with some academic colleagues looking at direct to consumer diagnostic apps, okay, which are not FDA overseen, because all you need to do is put "this is not for medical purposes" on your app, because after all, who doesn't want to find out whether they have skin cancer for entertainment purposes only, right? And I looked at the literature. We looked at the literature on that, and not only were there not a lot of studies, but most of the studies weren't really well done. And some of them were just kind of like, is this as good as a doctor? No, as opposed to, well, what can you use it for? And they don't distinguish between ones that use sensors, like the skin cancers apps, and ones that just ask you questions. And the mental health ones were terrible. The mental health ones were absolutely terrible. Now, are they better today? Well, I'm willing to guess that some of them are, some of them aren't, but the volume of apps is probably 5 times as much as it was a few years ago. So it's really difficult because this is an unregulated area. But the ones I've shown you are platforms that are being sold to employers or other kinds of things. So they have some checks on, they're not just somebody putting something up on the internet.
Yeah.
And lastly, the old problems of access and cost don't disappear, certainly, but they may take new forms. So for instance, with price data becoming available online, and there are now companies that are doing this high intensity kind of melding of price data and claims data that has outcomes, and they're trying to put together value-based data for every hospital in the country. Now, they're selling this kind of stuff, right, to employers and health plans and others. They're not giving it away. On the other hand, is there a place for advocates in saying, hey, again, maybe as a national group, we should have some access to this once we have a client or this, that, or the other thing? I don't know, but the important thing to me is you all, when you work with clients, make the client as subject. Too often, the other groups see the client as object. This is the person who I want to send here. This is the person who I do this on. This is the person I am consenting. All very well-intentioned, but however well-intentioned my health plan is, I'd rather have my health advocate have an equal amount of information as my health insurer. Next slide, please. So this comes from Danny Health Hacks Van Leeuwen, who some of you may know. Great guy, patient advocate, activist, really. Now on the board of Patient-Centered Outcome Research Institute, a lot of other kinds of things. And navigating the health journey is complex, treacherous, and emotional. The health partner, care partner, helps you navigate the health journey. And then the painting to the left is by Regina Holiday. Some of you may have her walking gallery jackets like I do. I had one of the early ones. Her late husband died in his, I guess, 20s of cancer, and she couldn't get the medical records and didn't have good insurance. And she's an artist, and she's been painting these portraits of capturing individual stories on the back of jackets that people send in, really, really beautifully. And that's really where I wanted to end, is that it does take an orchestra, it does take a group. Just the last one that has my contact information, you can just put up again for people. And it's important for the patient advocates to be part of that story. So that's my page. You can Google me enough. I'm the one who's not the oncologist in Philadelphia, who's the other Michael Millenson. I'm pretty fine. I try. Thank God we have different middle initials so that he doesn't have to explain to his physician colleagues, no, it's not me, it's that other guy. Anyway, I know this is a lot of material very quickly, but the essential idea is your advocacy is taking on a new dimension with some of the technological changes that we're seeing. And that while this is a challenge, it's a wonderful opportunity for you all to be even more effective in your advocacy, I guess. So thank you.
And thank you so much for taking us through that, and I encourage people to put their questions in the chat. And as you were talking, Michael, I was thinking back a lot of years ago at the start of my career when there was a thing called LexisNexis, which was one of the first databases
I remember that.
that you could search for information with something called Boolean language that you had to put in just the right type of characters and whatnot. So do you think, how long do you think it'll take for the AI models to make it a little bit easier for us to be searching information?
Well, the good news is it's really easy to search with ChatGPT and Bard. The bad news is it may not be accurate, but it's really easy to search.
Yeah.
And the problem is that, as I understand it, the large language model that they use hallucinates, even if it has an accurate database underneath, right? So you could say, well, the reason I'm getting bad information is this thing is searching the internet. And, in one site, it says that I'm 6'4" and look like George Clooney. And another site, it has my actual picture and it just chose the wrong one. But that's not the problem. The problem is that the way the thing is, the underlying technology is to make billions of different choices about what word comes next based on a zillion different parameters. And that underlying technology causes it to sometimes make choices which are false, but seem to be authoritative.
Right.
What I think will happen, though, is that it will become easier to search, and there's going to have to be some filters on the accuracy. I do remember the LexisNexis. It's difficult. I would say that I would never, when you do a regular Google search, at least the link tells you where it's from, and you can look directly at it, and you can look at where it's from, right?
Right.
And so all of us know, I'm just going to rag on academics for a moment. I was looking at a paper the other day, and patients are more patient-centered, right? And then you look at the footnote and it's something on the internet from 2010. Well, okay, yeah, they're more patient-centered, but really the best you can do is recycle the citations you used a decade ago. So we always have to be careful of the date of the stuff, and we always have to be careful of the other things. I mean, that's where your expertise really comes in, because democratization does not mean sophistication, as we all know from looking at, elections. So the other thing I want to say about democratization that really concerns me is when you look at CVS paying, $11 billion almost for a group of primary care doctors, and Walgreens and Walmart and Amazon and all the rest of these people, they are not paying out billions of dollars so that you can have freedom to do whatever you want. However wonderful they all are, they are paying out billions of dollars because they want more customers who will eventually give them billions of dollars. And so while they are sources of information, your skepticism to keep democratization from becoming a series of walled gardens where elites control, I think it's going to be very necessary. I have my concerns for some reason that people who have billions of dollars to spend will come out better than people who don't. That's just my suspicion, unfair though it may be to billionaires. But I think that you all are going to have an important role to play.
So somebody brought up the FDA, and I know that the FDA regulates drugs and devices, but generally has not been good at regulating, hasn't really, as part of its domain, regulated websites other than medical claims and whatnot. So what kind of government agency will be regulating AI? I mean, it just feels like it's ripe for that.
Depends how and where it's used. It's like we charge people with wire fraud based on laws from when there were telegraphs.
Yeah.
I think that people are starting to cope with this now. So the FDA regulates medical devices if they reach a certain threshold. So for instance, AliveCor, when it wants to sell its heart monitor on a watch, gets FDA approval because this is really important. Is your heart working right? Okay. Some of the direct-to-consumer stuff, don't bother.
Right.
And so websites are a whole different thing. I think what's happening with AI is because the potential harm is so great. You saw that meeting at the White House.
Yeah.
People are trying to figure out not just regulators, but whether new congressional action is needed. So right now, AI per se, leave aside ChatGPT and all those guys, that's generative AI. We've had AI in our medical devices and everything for a long time.
Sure. Where do you think Siri is, right?
Exactly. Well, that's exactly right. That's exactly right. So AI isn't the problem. Powerful AI that hallucinates and everybody can use to create images and stories that look exactly real is the problem. But I have heard of Doc GPT being used by a patient advocate to produce letters challenging a decision, right? So they can, and then they're reviewed by the nurses and then they send them out to overturn an insurance denial. So there are ways to use these generative AIs in sort of a, I'm going to take my Ferrari and go to the supermarket way that are safe with human overview. It's when you say, I'm going to take my Ferrari out on the open highway with no controls whatsoever, because what the heck, it's a Ferrari, is where, you can kind of run into trouble.
Mm-hmm. And I would imagine that most advocates are so focused on working with their clients that they might not be investing a lot of time in deciphering what AI support might be best suited for, just the BARD versus ChatGPT.
I mean, they're both easy to look at. Quite frankly, I don't know about you guys, but I'm not going to take the time to figure out how to get ChatGPT to answer my email.
Yeah.
I mean, that's great that some people are doing that and all the rest of that. Then you have to look it over. It ain't worth it. Whether you can use Doc GPT for some denial letters or whether you can do some targeted searches. Now, Google is coming out with a medical version called MedPalm, which I have not seen, and apparently they're keeping very close right now. So this is going to evolve. Those of you who are in Silicon Valley or whatever might, glom onto someone at Stanford or in Boston, some of the people who are doing informatics at the Harvard or MIT, and get an early look at some of this stuff, and then perhaps share your thoughts with those of us who are not in the techno elite.
And it's Doc CPT. Is that
no?
They
made a deal. Instead of Chat GPT, it's Doc GPT, and what it is that OpenAI and Microsoft are licensing the technology, so people are using this for various things.
Yeah, I wanted to say that
personally, I would recommend you all be careful.
Yeah, when we were prepping with Michael, I might be one of the older folks on here that, this is all new, and it's really important to stay up on and understand how to do the searches. That was what I took away from Michael. It's just like when we first had, autocorrect or, anything like that, you really have to understand how to do the searches and understand that the information might, you still have to be skeptical of anything you find and use the sources so that you can accurately give patients information. So,
and there's a story in the New York Times business section today. I haven't read it. They talk about, they asked, when did the New York Times first publish such and such? And they got 5 different answers and none of them were accurate. So
the accuracy.
It's a good article. It talks
it's
about, them buying up all the different health plans, or, everybody's kind of consolidating because they're making money.
Well, I'd like to hear from the advocates also, who's using AI and how are you using it, and what are the questions you have in terms of kind of what's going on right this moment versus what you see happening in the future, if anybody wants to
Just-
also pop in.
I want to stress that all of those apps that I showed, which of course do use AI and algorithms,
Mhm.
are not generative AI. They're using it in a different way. So for instance, they're searching, reported medical and healthcare data using an algorithm, not using the generative AI. So just to make that clear.
And
Can I just, before we step away from that a little bit, I think that caution is really, really important. And I think on the last community conversations, I mentioned this, that someone who was working at my home was saying, so masking doesn't work because this article came out and said so. And if you read the conclusion, you might come to that. It said it's not clear because there wasn't enough data. But if even if the AI companies and products are pulling up published data that might be valid data, if they're not looking at all of the content, they're going to give some wrong impressions. So we still need humans and all of you guys' brains and your connection with your clients to know, is this even going to matter? And I had real concerns about, I think it's fascinating. I love that it's looking at helping people to figure out diagnostic issues and those kinds of things, what their options are. But as you said, Michael, I'm afraid the poor people are going to be left behind on this. So that puts even more pressure on this, idea of volunteer advocates, because who's volunteering for poor people?
Mhm.
And the discrepancies that we see in their outcomes, both,
Mhm.
no matter what color their skin, but certainly when you look at Native American and Black populations. So I just want everybody to be thinking about this. All these new things have amazing potential, but also amazing risk.
Mhm. Karen, you have your hand up.
Yes, so I had a 900 telephone number. There was 99 cents a minute. People could call me and ask me questions. And I was using the Encyclopedia of Medicine. It was a big book, and people would tell me their symptoms, and then I could look up a little flow chart that would go through asking them various questions, if this, then that. So I see, even for, the layman, for people to be able to, use that, my question was, we're using it for marketing primarily. I think that it does a really good job of explaining what a patient advocate does, except that it said that I was a social worker instead of a patient advocate. It had some other company that, I looked it up. I tried to Google that person, Karen Isaacs, at this other company, and couldn't find that. I looked it up on LinkedIn and everything, and there was no Karen Isaacs that had that. I don't know how they found that part. But do you think that, how close are we to doing that? I think it's a better than people just, Googling. If we had something like the Medical Society coming out with,
Kind
their
of an advocate sanctioning credible information. I want to jump in and
Google
yeah.
made a deal a few years
Mhm.
ago now with the Mayo Clinic because of the problems that when you Google your disease, there's a little box that comes up from Mayo Clinic with reliable information on it. So they kind of address some of the Dr. Google problems by having up in, I have X, so people wouldn't do it. And what you've described with the flow chart is essentially what the semantic web is trying to do, right? It's trying to be personalized, interactive, and that's where we've been going the last number of years. So that's fine, as long as the source doesn't hallucinate. I think, when you come to medicine, I looked up my own bio too, like a few made up facts. When it comes to healthcare, to say, you know what, most of the facts that we gave you weren't made up, and you got your answer in a 1/10 of a second. So really, why are you complaining? It obviously isn't going to work. So I think that conventional AI is going to be ahead of the game for a while, but that's what these platforms are. That's what direct-to-consumer diagnostics are with Babylon or people like that. And so we have that. It hasn't caught on as much. The generative AI is a wonderful, flashy toy. I mean, it breaks barriers. It's just so right. It's Alexa and Siri, to a different dimension, but it has this accuracy problem. And other than destroying the whole world, we're not even talking about that because this is a healthcare conference.
Right,
But,
right,
so-
yeah.
But I mean,
And
for
I want to
purposes,
go ahead. I want to go ahead also and make sure that Rachel Westlake gets in here before we're out of time. Rachel, you had a question or comment? You're on mute.
Yeah, I was pushing the wrong button there again. Hi, thanks, Michael. This was great. I think that what comes up for me when I think about the access to this kind of pooled or pooling this actual medical information is that maybe that's not exactly what independent advocates need to be focused on right now, because we don't provide medical advice, and we want to make sure that we're more importantly, reminding patients that the programs aren't providing medical advice, that we don't provide medical advice, and that there are professionals for that we're helping them navigate their healthcare. But advocates can definitely add to the conversation around data democracy when it comes to how machine learning and AI is contributing to price transparency, and other ways that these tools can be used. So just joining in those conversations. Additionally, I think that this can save us a lot of time so that we can provide more services to more people by utilizing it in our business in other ways. I'm able to, create a proposal for disability self-advocacy in a shorter amount of time for a local organization here, because I can use ChatGPT to enter the information for the request for proposals and create a timeline faster. These are ways that we can come up with, time-saving efficiencies so that we can reach more people and perhaps provide more community services and pro bono services, because we're not spending time figuring out how to scale our work. So
That's a really good point. Thank you, Rachel, for sharing that.
But I just want to go to the beginning, though. The examples I use, because I know we all talk about ChatGPT and those, were coming from reliable kind of interactive things that an employer or a health plan or somebody might be providing. And I think, of course, you're not providing clinical advice in a certain sense, but in another sense, if I'm getting from a reliable platform on chronic disease management, I mean, there's a whole bunch of these, as you know, if I'm getting clinically relevant input, I think you all being involved with that, given your perspective, even as non-clinicians, is helpful. Going online and just doing a random search or doing ChatGPT or Bard, no. But if someone is getting some of these platforms, like for instance, Citizen, which also connects all the cancer stuff from all these different places in one place, I think what that will do is it will allow you all to have a different kind of conversation. I guess that's the way I'd put it. And so I completely agree with everything you said, and I thought that was a great, rounded perspective. But understand that some of the AI generated stuff and the right kind of AI will allow you to have a more informed conversation. And that's where I think part of your incredible value is that, you have wisdom. Let's put it that way. Wisdom is always useful.
And with that, I'm just going to go ahead and wrap up. This was a fascinating conversation. I feel like we could talk about this for days. This could be our next 3 community conversations. So thank you so much, Michael Millenson, for starting us on our way to really dig into this topic. And thank you, Del Reisner, for giving us the medical perspective today. And I just want to encourage everybody to keep an eye on our next community conversation. We haven't announced the topic or the speaker yet, but we will be hosting that on the second Monday of the month, which is June the 12th. And we will be hosting also a case review next month. So please keep an eye out for that. And we look forward to seeing you soon. Good luck. Take care.
Thank you.
Michael.
Bye, everyone.